Good morning, and welcome to a conversation on ethical considerations for a fair and effective healthcare system, sponsored by the Lucille Packard Foundation for Children's Health. My name is Chris Stilla. I'm from the University of Colorado, and I'll be moderating today's discussion. Next slide, please. I'm a professor of pediatrics and head the section of general academic pediatrics at the University of Colorado School of Medicine and Children's Hospital, Colorado. I provide primary care for complex children and do a lot of academic work related to that. I had the pleasure and the privilege of co-editing the supplement from which this article comes from that will be discussed, and would love to introduce today's presenters. Next slide, please. Today's discussion features one of the articles from the March 2018 of the Pediatrics Supplement entitled Building Systems That Work for Children with Complex Healthcare Needs. The articles in the supplement feature writing from leading healthcare providers, family representatives, advocates, policymakers, and researchers. We hope that these articles will clarify some of the issues that are more difficult around the idea of children with complex healthcare needs and point the way toward their resolution. You can access the articles in the series that was sponsored by the Lucille Packard Foundation and stay up to date on future conversations by visiting their website, lpfch.org/AAP supplement. This is updated quite regularly, and there's a lot of good information, so I'd love it if you would go to that website periodically. A few housekeeping items, next slide please, a few housekeeping items before we begin. The most important is to ask questions in the GoToWebinar question box. Every one of the webinars so far has been very lively with lots of discussion and is dependent on the good questions that you all will ask. So please feel free to use that question box. We'll have time at the end of the presentations for the presenters to answer many of the questions. One other thing that's important is all attendees will be muted for the duration of the webinar so that the questions will be submitted all through that chat box. A recording of the webinar and the slides will be posted afterward on the Foundation website and shared with all the registrants by email. Next slide, please. Now I'll introduce our speakers. We are pleased, first of all, to welcome Dr. Chris Feutner, a pediatrician, clinical investigator, and ethicist at the Children's Hospital of Philadelphia and the University of Pennsylvania. Chris is one of the lead authors of the article that we will discuss today, entitled Ethical Framework for Risk Stratification and Mitigation Programs for Children with Medical Complexity. In addition to Dr. Feutner, there are two other great experts on the field who will join us. I'd like to welcome Dr. Grace Wee, who is Director of Clinical Ethics at Loma Linda University Health and attending physician at Loma Linda University Children's Hospital, and also Chaplain Mark Bartel, Manager of Spiritual Care at the Arnold Palmer Medical Center in Florida. So welcome to all of you, and we'll start off the conversation with a few words from Dr. Feutner. Chris, take it away.
Thanks, Chris. And before I get started, I want to thank everybody, whether it be the afternoon or the morning, wherever you are, for tuning in. I also want to thank the Packard Foundation for their support and leadership in this project and this space, and also to Rishi and Chris for their efforts to pull together the supplement and all of the work that went into that. So for the next dozen minutes, I'm going to talk about the topic next up here on the screen. Next slide. And then you can advance to the, yep. I'm going to really focus on providing a high-level overview of the paper that I had the pleasure of writing with Theo Schall, Pam Nathanson, and Jay Berry around what might be thought of as a reconnaissance into the realm of programs that take care of kids with medical complexity. And I can't emphasize the following points enough. One, any program is going to have tremendous benefit for many children, many parents. This is an effort for us to anticipate some of the challenges that might crop up, some of the tensions that may be inevitable. And while I would love to offer at the end a way to resolve all of the problems, I think that would be naive to a degree, in that some of the tensions need to simply be identified, be articulated about in a fairly clear, transparent manner about the choices that people are making, and effectively managed in that regard, not necessarily completely resolved. Next. So let me start with sort of a wonky point, which is, what does this risk stratification and mitigation program actually mean? And it will become clear a little bit later in the talk that why we didn't just say an ethical program for programs for kids with medical complexity, but instead added these other aspects, is that this is how these programs actually work. They have to identify a group of children who are, quote, at risk, and that concept needs to be unpacked. And then there are specific interventions that are being done to lower that risk, to mitigate that risk. And what we're going to do as we move through this paper and through this talk is actually get a little bit into the weeds of how we potentially aim to benefit children and their families, and then think about some of the issues that emerge out of essentially the weeds. Next. So here's a high-level view of the overall point of the paper. If you're thinking to yourself, oh my gosh, that's complicated, well, that may be one of the points, that there are different components to any program that need to be understood and be at least articulated to oneself, so you can be clear in your own mind about what you're trying to do, but also articulated to parents, to program stakeholders beyond parents, and think about the pros and cons of different ways of doing things. So if you start at the top, being really clear about the purpose of the program. If you're going to evaluate the program, the next level is being clear about the perspective that you are taking. This becomes particularly important when you start to think about costs, of whose costs are you going to consider, everybody's societal perspective, or is it a narrower focus, and if so, why? In the middle, that little circular diagram is basically the loop that we go through in any kind of risk mitigation. You try to identify a problem that you want to either occur or not occur. You have to develop a model of who's at risk for having this event that you don't want to have happen. You, once identifying them, have to have a intervention that will actually lower that risk. Hopefully that results at the bottom, preventing the event or outcome, and that loop goes round and round as time passes. And there are, in the gray boxes, a number of issues that need to be thought of. You need to think about why that outcome, the value-based assessment of why a specific outcome or event matters. Hospital readmissions, potentially the development of a complication, potentially cost, are all outcomes that people have talked about, but they encode different values. The model itself, the prediction model, has issues potentially of accuracy and the actual costs of developing and maintaining that model, as well as the problems that can emerge about who is identified and who is not identified as being eligible for the program. On the right side, when you look at the intervention itself, is the intervention fully acceptable? Any intervention, no matter how lovely or good it is going to have associated burdens and costs. Are those being clearly articulated, even if it's simply travel costs and time for the family to come to clinic or to partake in the program? Is there a need for informed consent to participate in this program? Is it burdensome enough, or are there enough costs that the family might bear that they should really be formally walked through a consideration of whether to participate? Down at the bottom are a number of things. If people are upset that they are not involved in the program, or whatever aspect they're unhappy about, is there an appeals process? Is the program ultimately effective? Are the events being prevented? Are the beneficial consequences you hope to ensue being realized? Are there unintended consequences? Again, there is very rarely an intervention that does not have some side effects that are not desired or unintended. And then those aspects at the bottom is that being distributed across the whole population of children in a fair and equitable manner. Next. So here are a list of the considerations. Again, I'm going to have to be pretty breezy to finish in time, so you can go to the paper if you want to see anything, read about it in greater detail. But let's walk through these a little bit at a time. Next. So there are three main categories, one being about the benefits and burdens, potential harms of the program, two, about this fairness set of considerations about whether the program is distributing its benefits in an equitable manner across the population, including the details of how fair is the algorithm or the process that is identifying who gets to be in the program. And lastly, three issues of transparency. Next slide. So with regard to those benefits and burdens, it can be really, really helpful to be clear to the members of the program and to the parents of what the benefits are going to be clear whether the program has any solid evidence that its promises of potentially being beneficial are going to be realized. What are the potential burdens and costs, time commitments or otherwise, of participating? In terms of unintended consequences, it may also be important to think about what will happen if people are enrolled in the program and then the funding for the program ends. Nobody wants to be accountable for a program that is sort of shut down because it runs out of funding, but if that's a unfortunately realistic prospect, what will happen to people who have benefited from the program that suddenly comes to an end? Next slide. Now let's think a little bit about specific risk events and the values that may be encoded in those. As you look at this list, there undoubtedly are aspects of this that children don't want to have happen to themselves and parents don't want to have happen. But we've also seen, I'm sure each of us can think of examples where parents really did want a readmission, or there may have been a test that they wanted that people were pushing back against. And then there are the whole issue of costs, of whether the cost borne by the health system is being shifted in a variety of ways with greater home care use to costs that are being borne by the family in terms of either outlays of time or lost wages. Next. Those top considerations, which are really the chief focus of many of the evaluations, are a choice. We could potentially be thinking about other ways of measuring outcomes. These are potentially could be viewed as more difficult, more subjective, but some of them I think are as easily measured as the issue around readmission, hospitalizations, and costs that have largely dominated much of the dialogue about why these programs are necessary in terms of evaluations. So there's an ethic, which is to say a set of values that are informing the outcome measures that we are potentially targeting because of the outcomes that we are chiefly focused on. Next. So now comes a set of considerations that we often want to say are very important, but I have to admit get short shrift when we look at ethics consultations that we perform in our hospital or even policy level evaluations. People say they care about fairness, but it often sort of disappears with the issues around potential direct benefit or harm to an individual carrying far more weight in the minds of many people. But let's slow down and think about, is a program going to be fair to all potential people who could participate? Is the process of identifying patients and families who get access based on an objective measure? And is that measure accurately finding people who are at risk of the outcomes you're trying to prevent? Are there disparities amongst people of different SES strata or other disparities that exist in our population? Are those disparities being perpetuated by the way that this program is being rolled out? Conversely, I know many people would love to believe, and it would be great to have evidence that programs such as this actually diminish disparities. And that would be wonderful if people could demonstrate that. Lastly, is there a complaint or appeals process? Again, all of us are probably on the phone believing that we're good people, we run very good programs. There would be no need to have a complaint or appeal process, and it's the kind of thing you don't have until you suddenly desperately need one. And it should be there, built in from the beginning. Next. Another consideration that we talk about, but it's not really clear, we're not as transparent about our commitment to transparency as we could be. Are the program goals and focus clearly articulated? Are they in writing? Are they in public view? Could any parent very quickly be able to pull off of the internet or from a brochure or a sign at the entry to a clinic, be able to identify what the program is seeking to accomplish for the people who participate in it? Ditto for other aspects of the program. I call this sometimes the microphone test. Are we willing to assemble everybody who's involved in the program, step in front of the audience, and with a microphone talk about how the program is being delivered, the elements of it, the expectations of how we think it will work, and how we are evaluating the program. If we're evaluating it really to look at cost savings to the health system, and that's our chief evaluation, are we willing to tell that to the parents that we serve? They may understand that there is a logical rationale for being able to build support within a business model for a program, but if that's the only thing that's being evaluated, is that something that we are comfortable being very clear about? Next slide. Okay, I'm now going to very breezily go through the recommendations because this would take way too much time to go through in detail. Again, let me direct you to the paper. So first, next. There is, as I've already hopefully made clear, a real need to be clear, transparent with regard to program goals and the benefits, burdens, and costs. Next. The only way to do that is to detail the intervention, what specifically is going to be done, and what are the expectations of what those specific tasks will accomplish, and making those program features and performance metrics publicly available for the sake of transparency. Next. One aspect that needs to be thought through with real thoughtfulness and hopefully some evaluation is the accuracy of case identification. Especially if the program works really, really well, there's a need to make sure that it is being allocated to children and families on a fair basis, and that it is not prone to either inaccuracy or some kind of bias of referral as to who gets into the program. Next. As I've already said, nobody has it until they suddenly realize they need it, but adopting a formal and auditable consent and appeals process, set of processes, would be a very good preventative ethics. Next. Overall, you may catch a drift here that this is really thinking about the program and all of the stakeholders as engaged in the system of care and trying to make sure that when we promote programs like this, design them, promote them, seek to evaluate them, that we are aware of the choices that we are making in taking a complex system of caring for children with medical complexity and making the evaluation and management of such a program as holistically informed as we can, with a self-awareness of the choices that we have to make that task manageable. Next. So those are the high points of what I wanted to emphasize. Again, thank you for your time and attention.
Great, thanks, Dr. Feutner. And please come up with questions, ask them. They don't necessarily have to be perfectly articulated, but if they're out there, we can talk about them, and we'll go from there. I'll turn the microphone over to Dr. Grace Wee, who will talk about some different aspects of ethics and program development.
Thank you so much. Thank you, Dr. Feutner, for the important work that you're doing in this area of systems improvement. I thought this article was certainly a very thorough look at the process of creating a system of risk stratification and mitigation. And you and your colleagues have been very thoughtful in proposing this framework. My following thoughts are to build on some of the things that you've already brought up. I really appreciate the emphasis on transparency, the inclusion of multiple perspectives, and the attention to unintended consequences. When creating a system, the inclusion of multiple perspectives leads to the delicate act of balancing one interest against another, not because the intention is to favor one party over another party, but because reality often imposes limits and forces prioritization. This is the cost of creating the system, and the decisions that balance and form the decision will be made by individuals with a vested interest in preserving what has been created. Thus, I ask if a system, even one that is created with the very best intentions of fairness and justice, can achieve these ethical aims at the outset. I think that the formation of any system will have built into it the implicit biases reflective of the decision makers. Thus, systems need to be tended to like an evolutionary being, with particular attention paid to the unintended consequences that arise and to the workarounds that spring up as humans adapt to a new structure. With this thought, what mechanisms are we putting into place in a new system to recognize the implicit biases? I have always been fascinated by the research on implicit bias and its possible effect on real-world decision-making. Likely, both patients and clinicians approach the clinical encounter with implicit biases. However, generally, the clinician wields more power, and certainly in the creation of a new system that is meant to serve and to improve healthcare for vulnerable populations, the clinician definitely holds more power. This is not bad, but I think we should recognize the potential for institutionalization of biases and strive to correct it when able. We can only correct what we can see, and we can only recognize unintended negative consequences when we can seriously consider the perspectives of multiple stakeholders on a continual basis. One type of bias that I do worry about is the perception that health is separate from other factors that significantly impact a patient's quality of life. I'm thinking that most everybody on this call is aware of the social determinants of health, but even if a clinician or a program recognizes these social determinants, it can be difficult to determine which factors should best be enhanced or provided in order to improve participation in a risk stratification program or to enhance the efficiency of such a program. For example, gas cards and bus passes to ease the cost of transportation may not be very helpful to the families who cannot make additional clinic appointments because of other pressing responsibilities. As another example, home visits from clinicians may not be helpful if there is housing insecurity. Ultimately, though, the limit of social support provided for children with medical complexity will be determined by the society's attitude on distributive justice or deservedness. This, in turn, is dependent on societal attitudes on quality of life. Without serious reflection, quality of life determination can be influenced to an outsized degree on, well, implicit bias. And population research documents well-known biases against persons with disabilities. My last comment before I wrap up will touch on healthcare provider attitudes on the end-of-life care. Again, population research has shown a bias against disability, and research also shows that healthcare professionals have similar rates of bias as the general population. Likely this is because we practice within societal structures that may inadvertently reinforce negative stereotypes. My concern is that this may carry over into end-of-life counseling for families of children with medical complexity. This is not to say that we should not talk about the end-of-life care, quite the opposite. But we should ask for clinicians to reckon honestly with their implicit biases and to ensure that the focus on quality of life centers on the child and the family. Again, this is such an important topic, and it's a topic that touches all of us within our society. In addition to paying attention to the considerations outlined by Dr. Feutner, I'd also would like to suggest that we must also engage in the type of conversations that allow our society to grapple with concepts of fairness, deservedness, and bias within a system that we create and also within our society as a whole. Thank you.
Great, thanks very much, Dr. Wee. I see there's a couple of questions that are starting to come in. This is great. Please continue to ask them and we'll address them in just a few minutes. I'll turn the microphone over now to Chaplain Bartel, who's the Manager of Spiritual Care at Arnold Palmer Medical Center. And go ahead.
Thank you, Dr. Stilla. I'd like to also thank the authors of this article for their careful work in gathering so many aspects of the ethical development and operation of programs for medically complex children. When asked to comment on a well-done, expansive piece like this, and following the two preceding presentations, the only possible remaining response is to see if it can be pushed a little further out with equal benefit, out into those weeds, as Dr. Feutner puts it. Can we extrapolate in any direction to build on this foundation of ethical medical care? My challenge to us all is to push out farther in the distributive justice and fairness direction and ask ourselves, what about the programs that are not present? What of those complex disease states that to date have no champions or resources? Many such conditions still have no name, and of the 7,000 or so named rare diseases, many thousands have no research at all in progress today. What do the ethics of medicine ask us to do about these untouched rare conditions amidst our limited funding and research capacity? In light of our subject today and the ethics of caring for all medically complex children, I submit that we have an opportunity to speed up the process. What if every university, research center, and pharmaceutical company took on just one new rare disease? I'm not saying that there aren't already many endeavors of this kind already in process in the United States. Please know that I have great pride in our research in this country, and that's precisely why I'm hopeful that we can solve the mysteries and ease the great pain of these diseases. I'm also aware of the costs involved in modern research and medication approval. Hope for recovering some of these costs with rare disease medicine development is slim. That's why I'm asking, what if each center of medical research took on just one rare, poorly understood condition, though may not be likely to offer a good return on investment? With just one new piece of risk per center, we could nevertheless improve the quality of life of millions of our fellow humans. This is the theory behind insurance of shared risk. No single entity, including our government, should be expected to carry all the burden of so-called profitless research. And is it ever truly profitless if suffering is eased? These are not just numbers or demographic percentages. These are people like you and me who simply were unlucky enough to have a rare disease, 80% of which are genetic in origin. Let's not become so utilitarian that we blindly follow the path of doing only the most good for the most people. After all, that path avoids millions of suffering people in the aggregate, many of them children who will never grow up because they have a rare disease. Let's not research and treat childhood maladies in strict order of the numbers afflicted. That would leave these rare diseases to the end until all the more common ones are all cured. We need to research not in sequence, but in parallel. I admit the great risk in such a commitment, but the payoff is great as well. We will see more suffering eased and more hope given. Those centers who already engage in this research, and God bless them, know about the deep intrinsic rewards of their work as well. Are there not such intangibles as increased staff pride and strong staff retention through doing this work? And the gains in public relations are an added bonus as they take on this risk. Additionally, I know I would love to save families the time and expense of traveling to other countries for questionable and expensive treatments. Remember Laetrile? There's still many current examples. And speaking of the families, let's form better connections to locate all those with these diseases so that we can build the numbers, though small, that are necessary to better understand the mechanisms and treatments. Partnering with patient and family-led foundations and associations has proven to broaden our research significantly, and they long for our help. Similarly, those physicians and centers that are known for such work on rare diseases need to be supported. We all know families who can find only one doctor working on their child's condition and have to travel there for care. Both doctor and patient need the support to connect and stay connected as the process of discovery and healing progresses. As we progress, I believe that as we solve the riddles of one rare disease, we will unlock answers to others. Last century, Dr. Georgios Papanikolaou discovered how to find cancer in what we now call the Pap smear, and lowered by 70% the numbers of women dying from cervical cancer. Since then, we've discovered that this life-saving early diagnosis technique extends to other types of cancer, including colon, kidney, bladder, prostate, lungs, stomach, breast, sinuses, spine, brain, and blood. More recently, Dr. Timothy Yu and his team at Boston Children's spun off an idea for treating another rare disease, spinal muscular atrophy, in order to treat a young girl with a variant of Batten disease. More of these sorts of domino effects can be expected as we begin to understand more of our rare diseases. Discoveries in the cure of one will no doubt lead to treatments and cure for others, speeding the goal of curing these thousands of waiting maladies. We all entered the realm of healthcare to answer a calling to ease the suffering of our neighbors. I believe that fairness and justice means working for all our neighbors, especially the children, no matter how common or rare their suffering. Please, let's share the risk and each one take one condition and support through more just incentivizing those who are already succeeding in this work. We can accelerate their success as we each shoulder a small part of the load. There are many more medically complex clinics for the rare diseases yet to be established. Thank you.
Great. Thank you very much, Chaplain Bartel. We do have a few questions now, thanks to all the presenters. Actually, suddenly we have a lot. We may not be able to get to all of them because many of them are in a fair degree of depth, but I think that's good for a conversation like this. Please continue to submit your questions in the question box because even if we don't get to them in the next 25 minutes, the presenters will be able to answer them offline afterwards. I'm just going to go in order of the questions that were submitted. The first question is from Lisa Scheuer, and it's kind of long. I'll try and paraphrase. She's run into a couple of situations where the care for a child was framed by publications, literature, and essentially standards about the child's condition rather than the child's actual abilities, which might be outliers. For example, one was a child with Down syndrome who had really good motor skills, was able to skip and run, but multiple publications assert that Down syndrome causes low muscle tone, so physical therapy was not deemed to be helpful. Another was a child with trisomy 18, where the family was not offered treatments that might be successful given the poor prognosis of that condition. So she's looking for essentially some thoughts about how to create good therapies and welcoming environments for kids who might be outliers for certain conditions. And I'd love to hear about from any of you about your thoughts about that.
Well, this is Chris Feutner. I'm thoughtful that the paper that we wrote was really about the programmatic management of a population of children, not the individual clinical care of a given child by either a given practitioner or a group of clinicians. And that question, which I think we all encounter, where published guidance does not seem to fit a particular case, occurs in not just clinics for children with special healthcare needs, medical complexity, but in just clinical care generally. And it really would be applicable to any of the customization or personalization of care, which could be done by fancy genetic markers, and I don't mean to disparage them. I mean, really remarkable things going on in cancer and other realms of basically customizing care to suit a particular patient based on a much higher level of phenotyping of what's going on for them. And in this case, it sounds like this patient, if you really phenotype what they're capable of doing, they are not suitably placed in the care pathway that has been published. That, to me, is a very important set of considerations, and the ethics of how people get boxed into a certain kind of treatment based on stereotyping of, a patient with this condition is always going to be like this. That stereotyping has real ethical implications and problems if it is inaccurate. That's why I think we've seen such a move towards customization. So I would just put the clinical judgment of clinical-based phenotyping alongside the technical developments of more sophisticated phenotyping, genotyping, and say they're the same thing, personalized care.
This is Grace Weher. I just want to thank the question for this question because I do think that this exemplifies some of the unintended consequences that can be created when we attempt to standardize, the type of care for patients. The unintended consequences of saying trisomy 13 is uniformly fatal is that, well, it's uniformly fatal if you don't treat them. But I agree with Dr. Feutner's point of having to really look at the functional status and the phenotype of the patient instead of the genotype. But, without good attention to how these unintended consequences arise, and without a mechanism in place in order to advocate for these types of patients, I think that is a very real concern, though, that we, in our zeal to improve population health, this may come at the expense of individual patients.
Great. The next question is from Clarissa Hoover, who was interested in the opinions of the presenters about unintended consequences for siblings and other family members from an ethical perspective. I know that's really broad, but a couple quick examples would be good.
Well, for starters, we were just talking about personalized care, and while everybody thinks that's exactly what they want, personally, that's not what I want. I want to be part of a group that has been well studied, and my problem that I have is well understood, and I can be put on a very evidence-based clinical path. I'm likely to have the best outcome that way. So I think as we focus on the unintended consequences of, say, having a known condition with known associated problems, there are some benefits of good characterization of a population of people with a condition. The unintended consequences as we shift from the patient to the sibling, again, I think it would be important to talk about the intended consequences. So I think most of us would love to believe that our programs for children with medical complexity is going to reduce stress in the family, going to help them manage their time more efficiently, that they're not going to waste as much time, and that as a consequence, there should be collateral benefit for the siblings of the child who has got the condition participating in this program. There's an awful lot of concern on the part of parents about what it does for brothers and sisters to have a sibling who has a complex condition. To the degree that we have studied it, it appears that these brothers and sisters are developing quite normally. And there's some suggestions in the literature that perhaps there's even some benefits of having a sibling who requires more and in a sense invokes in the brother or sister an idea of selflessness of needing to not just consider their own interests when they're children, but the interests of their brother or sister. So those are the things that we hope for. I think the unintended consequences would come if these programs don't yield the benefits that they're hoping to yield, where inadvertently trying to participate in the program is subtly pushing more work back on the parents or put more stress on the family in ways that we certainly hope is not the case, but that's where I would see the main downside for the siblings, is if the programs don't do what we hope they are going to do.
I have an example for Clarissa about siblings. This is Mark. Years and years ago, when we could still do this, we took our cystic fibrosis patients out on trips around here. We'd go to the Orlando theme parks or to shows or plays or whatever. And some of the siblings were jealous of that. One of them actually told me once, I wish I had CF too, so I could go do all these fun things. And so we had to rethink and make sure that while it was fair enough that we were getting these patients together and you know, helping them to a little bit normalize their experience, since so many of them were the only one in school who had it, for example, we still needed to remember these siblings who were part of this patient's life, and we didn't want to neglect them too. So we had to balance the trips we took and try to include the siblings when we could, because as Dr. Feudner was saying, there are a lot of good benefits to being part of your siblings' care and understanding what they're going through outside the home as well.
That's a great example. You know, and I think that that Chris Feudner's idea of designing programs with siblings in mind is something that the program designers often don't do. So, yeah, thank you, Clarissa, for that question, and thank you to the presenters for your great answers. I'm sure we could talk more about that another time. The next question is from Tom Kelly, who is interested in the perspectives of the presenters on who are the stakeholders and key components of the system. We've identified patients, families, and siblings, and maybe just talking a little bit about the other stakeholders, some of whom may not be obvious to the listeners on this webinar.
Always important to, again, be clear, thoughtful, and then clear about who are the stakeholders in general in the universe, and then be clear about who you can engage with and who is going to be sort of silent. You know, for example, we were just talking about siblings, and they probably are not going to have clear representation. Certainly the young siblings and their perspectives won't be represented, but they can still be considered and thought of. I think people typically would list on the organizational side of healthcare and the business side of healthcare, people who are going to be involved in funding the program, whether it be in some way self-funding through billing mechanisms or funded through philanthropy or grant support. Anybody involved in that side of the equation, what do they need to see coming out of the program to continue to provide that funding? There are going to be other members of the healthcare system who are clinically active, doctors, nurses in perhaps primary care settings, but not part of this particular program. How do they view the participation of patients of theirs in this program? The hospital. So, and members of subspecialty teams, do they feel that the program is facilitating the care that they're providing to patients, et cetera? And I'm sure we could go on with this list, but the key point I would make is that where Grace talked about implicit bias, I would actually just simply note that there's explicit bias or explicitly stated priorities. And one of the main priorities that we have dealt with for a long time is this call that any program like this needs to either be cost neutral or cost savings. And I'm steadfast in pushing back on that frame that is imposed by certain stakeholders who are saying we can't support this, or they just assume the program will not be supported unless it is cost savings. There are very few ventures in medical care that even come close to trying to make that claim. So I just want to emphasize, I think that there are real issues about both who the stakeholders are and being clear about the explicit goals that they may have for a program. I will say some people who provide funding and support are incredibly not about the business model bottom line. They're thinking about value to the family, improvements in quality of life, of the value proposition of these programs, and that's where I think we need to go.
I think of another stakeholder. Oh, sorry, go ahead, Dr. Wee.
No, go ahead, Mark. No, go ahead.
We also think about the community. I think especially in pediatrics, our town is very involved in caring about how well we do. It matters to them a lot. I remember a friend in San Diego telling me that the way she put it was, our children's hospital is the crown jewel of the city. And it really struck me as like, wow, the community really cares how well we're doing as well. So the stakeholders include them, and it matters to them. And here in Orlando, after the Pulse nightclub shooting, our adult hospital next door obviously did so much work that night and did very well with it. And the community support and gratitude was matched by their just their need to know that we're still around, that we're learning from that we're doing even better now, we're even more prepared. And so I would say to Tom that the community is another stakeholder as well.
I would wholeheartedly agree with that. I mean, to me, a stakeholder is whoever we are accountable to. And because any sort of program like this, which is probably going to be housed within a certain medical system, is situated within a local community, we must include the community when in our engagement, because again, we're accountable to our community. We want to make sure that they understand the aims and the aims of a program such as this.
I will jump in though and emphasize, in my view of the world, which everybody else can disregard, our chief stakeholder is the child. And then right outside of the child are the family. And then outside of them are all the clinicians who are trying to do good by the child and by the family. And I do have a kind of concentric circle notion of also how we would prioritize these. And the community, which is to say people who are not directly involved in the care of the child or the child's life, but indirectly, I agree that they are stakeholders, but they're somewhat attenuated. And I emphasize that because I think we can get a loss of focus, a diffusion of our focus on what can we do to help this child and this particular family when we start to invoke too many stakeholders and don't really prioritize them.
Great, thanks. I'm going to ask, skip a couple questions to one that I think is a good follow-up for what we were just talking about. Kristen Knudsen is a pediatric private duty nurse, home care nurse, and serves a client with medical complexity, essentially doing an in-home medical intensive care unit. So how can home care nurses, especially ones that are that involved in large amounts of day-to-day care, be included in a model that builds an ethically solid model of care?
Well, again, going back to the framework that we sketched, I think one, all due honor to somebody who's in the home. I've walked into homes and watched moms and dads run essentially the mini ICU out of a supply closet in a bedroom, or the first floor living room, and it's always humbling to see. Those are the people who will know most about what most needs to be done to improve the quality of life or the outcomes for that child. So when we talk about specifying program goals, they are the ones who I think can bring that focus I was just alluding to in my prior comment on what do we do to help this child, and then from the degree that either the parent, him or herself, can specify this, or somebody who's that involved in the home can see what is going on and what would be truly helpful to the parents. That's clearly where we need to be almost laser-like in understanding what are we trying to accomplish so that we can engineer a program that has got the greatest likelihood of delivering on making those outcomes better.
Great, thanks. And any other thoughts from the other panelists before we go to the next question?
Just that people like Kristen are the salt of the earth, and keeping these children going and the ability to keep them at home is a huge part of, I think, what most of us running or part of a clinic like this want. We want the child to be able to be at the home with the rest of the family and the siblings that we were talking about. So to add to Dr. Feudner's point that the home care nursing folks are going to know the child very well, they're also a big part of making sure our deep, heartfelt goals are happening, and that's to keep the family intact under one roof.
Great, thank you, Mark. The next question is from Dr. Sarah Eaton in Medical Ethics in Switzerland and also University of Miami. She's interested in how a standardized policy on facilitating shared decision-making for patients and families might be integrated into designing programs under an ethical framework. She's doing some work on standard decision-making, shared decision-making, trying to read and speak at the same time, and wondering about what components of an effective program might be.
Well, I can put in a plug at this point for another supplement that will be coming out in pediatrics sometime in the next couple of months regarding shared decision-making in the pediatric context, edited by Wynn Morrison, John Lantos, and perhaps some other people. I apologize if I'm forgetting. The reason I point to that collection of articles is that while we talk about shared decision-making and, I don't know, sharing was something I learned in kindergarten, it's a good thing. I think when we really stop and ask what does that mean in detail, we start to have very divergent notions of what it would mean to share a decision. Clearly, there are very good communication practices, very good ways of providing information, very good ways of potentially collaborating on the other side of a decision to enact it. But how we actually go about the making of the decision is a complicated space. And while I think that there are better and worse ways to do it, I think that that collection of articles is pretty clear that we're not at a point yet where I could figure out how to, quote, standardize an approach. I do think, and that's what we were raising a little bit with the idea that perhaps parents should be given the opportunity to be fully informed and to offer their consent about participating in such a program that we're talking about today, is moving towards a thoughtful process of how do you inform, make recommendations, solicit values, and then come to a decision as to whether there is consent to move forward or not. And to that degree, I want to both embrace what the question is asking and also point out I think we have more work to do to figure out what best practice in that space would look like.
Yeah, I would agree that there is such a wide variety of definitions under shared medical decision-making. One thing that we could do, I think, is to build and support the creation of relationships in any sort of clinic process. And for example, this would include making sure that there is enough staffing and consistent staffing that is available for these types of relationships to be built. Sometimes within a system, without, I think, clear attention to how many people that you need to clearly staff and who is who's going to be there on a consistent basis. There could be a tendency to devolve in a haphazard sort of staffing, which would not, again, lend to building of relationships.
I would add that to Dr. Feudner's point of how tough that is to even think about standardizing, going back to Clarissa's question about the outliers, kids who are high achievers, there's some families that are high achievers in this, and they do very well, and they collaborate well with the medical team, and it flows well, but then there's other families that really need a lot of help with it. And so it kind of related to the same question of standardizing anything involving humans, I guess. And so I would be interested in seeing those articles as well, because sitting in a lot of those discussions between families and physicians and the rest of the team, it really, the variety is stunning, and a little bit overwhelming to imagine being able to standardize it. That being said, I think that there are things that we shouldn't ever do, and there are ways that work most of the time. And so we could definitely come up with best practices, and I would applaud the work, any work in that area.
Great, thanks. We have 1 more minute, and I'll just present the question and maybe ask for one answer. Tom Kelly asks about rare diseases and generally what are the current big barriers preventing individuals and their families from finding better care for those rare diseases within complex care programs.
Yeah, so if I can take a swing at that. So whereas Mark really emphasized the opportunity and a plea to invest more in rare disease research, I think these programs start with the proposition that even with advances, there are still going to be children who have medical complexity who need to be cared for, who have either born before a cure was found or their disease does not have a cure. We are very soon all going to have our rare disease. Not necessarily people who are completely healthy, but anybody who is ill with a whole host of things that we think we now have a label that fits them. They're getting subdivided genetically and even at the protein level into increasingly fine, small categories of disease states that I think we're in a flux right now where understanding the implications of the rareness of the disease and the implications it has for how the child should be cared for. There's likely to be very specific molecular responses to rare diseases. But I will wager that over the eons, we're going to find that there are certain care practices that when the disease has progressed, that there are commonalities that span across these rare diseases. So if there's a level of neurologic impairment or cardiac impairment, there's still going to be, hopefully, tried and true and evidence-based ways to take care for patients beyond the individual molecular level of the origin of their condition.
Great, thanks, Chris. And I'm sorry we don't have any more time for discussion on this great question. We do need to close. It's 1 minute before the hour. Thank you all for attending today's conversation on ethical considerations for a fair and effective healthcare system. It's hard to do this justice in 1 hour, but I think you all have done a fantastic job of doing everything we can in that time. The next and final conversation will be just 2 short weeks from now on November 7th on the effect of payment models in children's healthcare. A recording of this conversation that we've just had and the slides will be sent to all attendees and posted on the Foundation website. We're always looking for ways to make these conversations more engaging and welcome any feedback you might have. Again, we'll answer the remaining questions that we can offline from the presenters. And please be sure to complete the survey that pops up at the end of the session. Thank you all very much. Thanks to the presenters. Thanks to Amanda Lanzaplain for organizing this and the Foundation for sponsoring it.